Hi there, my name is Dr. Zara Patel, and if you're watching this video, you are either deciding or you have already decided to have endoscopic septoplasty and or turbinate reduction. So first, let's just talk a little bit about what can cause the septal deviation and turbinate swelling, and then we'll talk about what you can expect before, during, and after surgery. So just as a reminder, because we've probably already talked about this in clinic, the septum can be deviated either just from the way that your nose developed when you were growing as a little baby, or it could be from some prior trauma that you've experienced. Either way, there are generally two broad categories of how you can do a septoplasty, depending on where in the septum the septal deviation is. So if the septal deviation, if we're looking from front to back in the nose, is a little further back in the nasal cavity and not part of the support structure of the nose, then you are a candidate for endoscopic septoplasty, meaning using that same camera I've looked in your nose with in the office, all through the nasal cavity and no external incisions. Now, this very top part of your nose and very front part of the nose of the septum, that's part of your structural support. So when we do an endoscopic septoplasty, I can just go inside, make a little incision, lift up the lining, and remove those deviated, deflected portions of bone and cartilage, lay the lining back down, and sew the mucosal surfaces back together in the middle. That works really well if you don't have the structural support involved. If you did, then just removing those pieces would not be enough. You need then to have the structural support rebuilt. If you're someone who has a septal deviation that's involving this very top or very front part of the septum, then you are more likely to be a candidate for what's called an open septorhinoplasty. And that's something that my facial plastics colleagues actually specialize in. And I will have talked with you about which one is best for you. They can actually make a small incision, lift up the lining, work on removing the deviated portions, but then they will also reconstruct the support where you need it, right in the middle, before they're done. So some people have a deviation that's right on the border, or they have something involving the front, but they are not really bothered about feeling asymmetry in the nose, and they just want an overall improvement, and maybe they'd be okay with still feeling a little more obstructed on one side versus the other. If that's the case, then we may have discussed going ahead with a minimally invasive endoscopic type of septoplasty, knowing that you will still feel asymmetry after the surgery, although overall, maybe your overall nasal breathing will be improved. If that's the case, then certainly some people are candidates for moving ahead with that endoscopic portion, and then keeping in mind that if they needed to have something done in the future, they always could with our facial plastics colleagues, if they were still bothered by that obstruction or asymmetry on that one side. So having said all that, let's talk now a little bit about the turbinates. Again, there's different reasons why your turbinates might swell. There are different things that cause irritation or inflammation in the nasal cavity. The most common thing would be allergic reactivity to things in your environment, whether it's pollens, grasses, or actually not even true allergic reactivity, but more of an irritant phenomenon, reacting to things like pollution in the air, particulate matter from forest fires, different things like that. Sometimes just using a CPAP machine and having forced air pressure can cause irritation of the lining. There are many things that can exacerbate swelling of the nasal tissues. Doing a turbinate reduction can very nicely reduce your turbinates back down to a normal level. You don't want your turbinates completely removed because you need that turbinate tissue. Turbinates function to humidify your nose. They function to sense airflow into your nose. They function to direct airflow up higher into your nose. And so you really need that tissue, but you probably don't need it as big as what yours is now. We can just reduce it back to a normal size. As long as people are thoughtful about how they're reducing the turbinates, then you shouldn't be at risk for having over resection. Symptoms from having too much turbinate tissue removed can be things like dryness or not being able to sense airflow, even though there's a large nasal cavity for airflow to go through. So we're very careful about making sure we're reducing it in the correct way. So now that I've kind of talked over the surgery itself and why you might be coming to this point, it is also important to think about surgery in the right context. Surgery is great at giving you a new anatomy, opening up the nasal cavity, and really allowing better airflow. But what surgery does not do is it does not change your underlying reactivity to your environment around you. And so if you've had swelling of the turbinates from that reactivity, that will continue. And doing things like rinses, sprays, topical therapy after surgery is just as important as having tried it before surgery. And it will probably be more effective after surgery when it's able to get in a little bit better. And that is really what can keep you at that good new baseline that I can get you to, instead of just swelling right back up and getting back to where you started. So let's talk a little bit about what you should think about in the week leading up to surgery. So we will want you to stay away from medications and other herbs and supplements that could potentially thin your blood. So very common medications that thin the blood are things like aspirin, Advil, Motrin, ibuprofen, all of those NSAID type medications. And there are other herbal type and vitamin type supplements, things like vitamin E, ginkgo, omega-3, ginger, things like that that can thin your blood, garlic. And so we would just want you to kind of hold off on all of those vitamins and supplements in the week leading up to surgery. And we'll give you a whole list of the different things that could potentially thin your blood. If you're on a blood thinner, like you've been placed on one by a physician because you need your blood thinned, then I would want you to speak with that physician, whoever has prescribed the blood thinner, and make sure that you can either stop it if it's safe for you to do so, so that we can not have too much bleeding during and after surgery, or if it's not safe for you to stop it, then develop a plan with that provider as to bridging you to a shorter acting blood thinning medication that we can start and stop as needed if you did have increased bleeding during or after surgery. So right before surgery, usually in that first week, also right before surgery, the anesthesia team will reach out to you and also make sure that you're otherwise healthy to undergo general anesthesia. If you have any other specific underlying medical problem, then I might have you reach out to that specific other provider to make sure that they think that you're optimized and cleared for general anesthesia with respect to your heart or your lungs or whatever the issue may be. So once you get to the day of surgery, they usually have you come about 2 hours before the surgical start time just to get you ready and prepped. The surgery itself would typically take about an hour and a half, something along that line. Add a little bit of time to put you to sleep and wake you up, and you do go all the way to sleep under general anesthesia for this type of procedure. And then after surgery, it usually takes about an hour, hour and a half to recover in the recovery room. So you'll be here for a good chunk of the day. And you do need someone to drive you home. Even though this is an outpatient procedure, you get to go home the same day, you will need someone to drive you home. They won't let you go home on your own. So having said all that, let's talk a little bit then about after surgery, what to expect. Or actually, first, let's talk about potential complications of surgery. That's really important for you to know before you undergo surgery also. So specifically, when we're thinking about surgery anywhere in the body, those are general surgical risks. So things like infection or bleeding. As far as infection goes, I'll be giving you a dose of antibiotics during the procedure to try to avoid anything like that. There is actually great data showing that we don't need to send antibiotics after surgery, that there's no difference in infection rate whether you do or don't get antibiotics after surgery. So I won't be sending antibiotics to your pharmacy for you to take after surgery. You don't need to take that. As far as bleeding, I'll control all the major bleeding while you're still asleep during the surgery, but you should expect to have some oozing of blood out of your nose after this type of surgery. That's totally normal and expected. And typically, I would say it lasts for the first 3 to 4 days and then starts to taper off. Although for some patients, it can continue to have a slow, steady ooze for the whole first week, and that's okay. If you did have a larger bleed, like a gush of blood instead of that slow, steady oozing, which I don't expect you to have, but if you did, then the first step of trying to control that would be to get a nasal spray called Afrin. It's AFRIN, very common over-the-counter type of nasal spray which is not good for you to use on a regular basis long term, but is really good at stopping nosebleeds. And so if you just have that on hand, you'll give yourself some sprays of that in your nose and then hold really hard pressure down low over this fleshy part of your nose for 10 minutes straight. And 99% of the time that will stop or slow back down any nosebleed. So that would be your first step. And if that wasn't enough to control the bleed, then certainly you'd call my office and we'd let you know what to do from there. So that's general surgical risks as far as, infection and bleeding. Specifically, when we're working in the nasal cavity on the septum and on those turbinates, I've kind of already gone over the potential risks of turbinate surgery if you aren't careful about the way in which you reduce the size of the turbinates. But when you do that surgery carefully, I would say that's not really a risk that you have to worry about. The only additional specific risk when we're talking about septoplasty is something called a septal perforation. So when we do the septoplasty, we lift up the lining and remove those sharp deviated portions of bone, and sometimes that can cause a little tear in the mucosal lining around the bone. If you had a tear at the exact same spot on both sides of the septum, that could potentially lead to a hole, what we call a perforation. Now, that is very rare for that to happen. And if that were to happen, from reports in the literature, people are in general not very symptomatic. Most people who have that don't realize until someone looks in and tells them you've got a hole in your nose. But if they are symptomatic from it, the symptoms could be things like feeling turbulent airflow go back and forth in the nose. If you're sitting very quietly, hearing a whistle of air go through that very small hole. Sometimes people, if they get too dry, can have crusting or bleeding from a septal perforation. And so I would say those are things to know about. But again, this is a very rare thing to happen, very minimal risk, especially when you have surgery from a rhinologist, someone like me that's done extra training to just do nasal sinus skull base surgery. And I've done over 5,000 of these types of procedures. The risks are extremely low. Other things to think about as far as risks, which are also extremely low, would just be general nasal and sinus type of risks where you think about the structures that we're working around or near the eyes, near the brain, near the nerves of smell. All those structures you'd have to say are at risk, but again, extremely, extremely low risk in this type of very directed, minimally invasive procedure. So now that we've talked about that, let's talk a little bit about after surgery. In that first week after surgery, you're going to feel very congested and stuffy just from the swelling of surgery inside your nose. You will have blood oozing out, like I mentioned. And in general, you're going to just feel very tired from the general anesthesia. People feel kind of exhausted and fatigued, and that can last the entire first week. So I just want to make sure that you're taking off of work or school or whatever you're doing, because you're just going to have to get through that kind of tough first week. And the other things to think about are things like no strenuous activity, no heavy lifting, no bending over, so no putting your head below your heart. All those things can increase your blood pressure and so make you bleed more. So I just want you to hold off on all of those things. Then you come back to see me for the first post-op visit, which is usually about a week after surgery. And that's when I go in and I suction out whatever blood clot you haven't been able to rinse out on your own. And I do want you to start rinsing the day after surgery, no later than that. And that'll help you get out blood clot, make you feel better. Even if it's difficult because of all the swelling and blood clot in there, I want you to continue to try to rinse that whole first week. Even if you feel like it's not actually getting in very well, I want you to keep trying to do that. Because then at our first post-op visit, it'll keep everything nice and humid and moist for me to remove as easily for you as possible. Now, keep in mind, it'll just be a week after surgery. You'll be pretty sore and tender inside. And so I want you to remember to take one of the pain pills that I'm going to be sending to your pharmacy right before that visit. So about an hour before that first post-op visit is typically when I want you to take it. The only things that I'll be sending to your pharmacy are that pain type of medication. So that's a heavier narcotic type of pain pill. And not everybody needs that heavy narcotic type of pain pill. Some people do just fine with a Tylenol. But if you did have more severe pain, I want you to have pain medicine to treat it. And so I will send that for you. If you get to a point during the week where you feel like it's not that bad, or you even start out feeling like it's not that bad, then just taking Tylenol is fine. But even if you've been on Tylenol that whole first week, I want you to take one of these heavier pain pills before the first visit because it will make it a lot easier for you. Just to keep in mind as far as the prescriptions I'll be sending for the after surgery to your pharmacy, along with the pain pill, whenever I send a narcotic, I also send a stool softener because it can make some people constipated. And I also send an anti-nausea medicine because it can make some people nauseous. So you just take those along with it as needed. And if you stop taking that heavier pain pill, you don't have to continue taking those either. Okay, so back to our first post-op visit. I'll have cleared all that blood clot out for you. You'll feel a little bit better after that first visit, just a little bit more open, but you'll still have swelling from surgery. And it'll just take some weeks, a few weeks for all that swelling to come down and for you to heal up all the way. You'll basically be coming back to see me 2 to 3 weeks after that first visit, a month after that, 3 months after that, 6 months after that, until I really feel like you are perfect. And I'll eventually let you graduate from me at that point. But keeping in mind that during that whole healing period, 4 to 6 weeks after surgery is usually when you're going to feel like you're at your new baseline. So just be patient and allow that entire healing process to take place. And again, as long as you continue doing the topical therapy that I ask you to, things like rinses, sprays, whatever we need to have you on medically to control whatever underlying reactivity you have to the environment or anything else, then typically people do extremely well with this type of surgery. I think that is all the information I needed to give you about this type of surgery. So certainly if you have any questions after hearing this, you can always call or message our office, and my nurse practitioner and fellows and nurses and staff are all very happy to answer your questions. If any of them don't know the answer, they'll let me know and I'll reach out to you and answer the question myself. All right, I hope that you have a great experience with this surgery and that you do really well. I'll see you soon.